So let us dive into the beauty of neurology. And first, I'll be talking about the basic concepts. Then we'll be moving on to the advanced stuff. The basic concepts are going to be some neuroanatomical concepts. To begin with, I'm going to talk something about cerebral hemispheres. You can get quite a few questions from this area. You're going to have something called as the central sulcus. It's also called the central sulcus of Rolando. You all know that. And then immediately anterior to it, you're going to have something called precentral gyrus. Immediately posterior to it, you're going to have something called postcentral gyrus. So what is the function of the precentral gyrus? The primary motor area, the motor function. Postcentral gyrus, that's in the parietal lobe. It's going to be sensory relay. The sensations that's going to be perceived by anyone is going to be in the postcentral gyrus only. So what will be the Brodmann distribution of areas? So precentral gyrus is going to come under the Brodmann area number 4. So that's the primary motor area. And the postcentral gyrus is going to come under the Brodmann area 3, 1, and 2. It's called as 3, 1, 2. This is the order that's arranged. And what is the function of postcentral? As I said, it's going to be the center for sensation. The primary somatosensory area is going to be the postcentral gyrus in the parietal lobe. So anterior to the central sulcus is going to be the frontal lobe, and immediately posterior to the central sulcus is going to be the parietal lobe. And you have the Sylvian fissure. This is also called as lateral fissure. That's going to serve as a distinction between the frontoparietal with that of the temporal lobe. And one interesting thing with regards to the precentral gyrus is going to be the motor homunculus. And of course, the homunculus is there for postcentral gyrus also. But once you know the motor homunculus and the precentral gyrus, you will be obviously equating that with the postcentral gyrus as well. And what about the arterial vascular supply? If you look at most of the lateral aspect of the brain is supplied by your MCA, middle cerebral artery, that is shaded in red here. And most of the anterior aspects, anterior-most aspects and slightly superior and medial aspects of the brain are supplied by anterior cerebral artery, which is shaded in yellow here. And if you look at the posterior and the inferior aspects of the brain, this is actually supplied by your posterior cerebral artery. If you look at the motor homunculus, the areas that are going to supply the leg and the lower limbs are going to be located superiorly. And to be honest, it will be extending to the medial side as well, which is basically under the ACA territory. So that's the reason why whenever the ACA is affected, whenever there is an ACA territory, in fact, you're going to affect the leg more than other parts of the body. So leg weakness is characteristic of ACA infarcts. Cortical infarcts is what I'm talking about. And if you look at MCA territory, this is going to supply the primary motor area, that's going to supply the arms, the face, and so on. To be honest, in the motor homunculus, the largest supply is going to be for the face, then the tongue, then for the hands and the thumb especially. So if you ask me the biggest area, it's going to be the face only. There's no doubt about that. So arms and face are going to come under the MCA territory. So if you're going to have an MCA cortical infarct, you're going to predominantly develop a contralateral hemiparesis, but it will be worse in the arms and the face. And feet will of course be spared because feet is typically on the medial side. Okay, that's going to be on the medial side. So feet will be generally spared in MCA stroke. So I can say if precentral gyrus is involved, especially in MCA strokes, you're going to result in contralateral hemiparesis. But depending on whether it's ACA affected or MCA is affected, you're going to have predominantly leg or probably arm and face weakness. I told feet will be spared in cases of MCA stroke. Similarly, if you're going to have postcentral gyrus involvement, you're going to have contralateral hemisensory loss, or we can say hemianesthesia. But the classic feature is you won't have equal involvement of all modalities of sensation. Of course, there will be homuncular pattern here also, depending on whether it's ACA or MCA. But if you look at the crude sensations, you have pain, temperature, crude touch, light touch, then proprioception, cortical sensations, and all those. What will be primarily affected in cortical strokes are going to be your cortical sensations and probably some posterior column sensations. But the pain, temperature, and crude touch as such can be perceived to some extent in the thalamus itself. That's the reason in a pure cortical stroke, you won't have that much involvement of pain, temperature, and crude touch. So it can be still a bit intact. So there'll be kind of uneven distribution with regards to sensations when it comes to cortical stroke, but cortical sensations definitely will be lost. So like you're going to result in agraphesthesia and astereognosis and so on. And after this, we have an important area in the parietal lobe. So this area is called as inferior parietal lobule. Inferior parietal lobule is a combination of two structures. One is the supramarginal gyrus and second one is the angular gyrus. In that the angular gyrus is very, very, very important because it's going to result in one unique syndrome called as Gerstmann syndrome. It's going to come under area number 39, area number 39 when it comes to Brodmann zones. And if you look at the problems of the angular gyrus, it could be problem of the left angular gyrus or right angular gyrus. If you have problem of dominant, that is left angular gyrus, actually in most people the dominant hemisphere is the left. Very few people will have right as the dominant, very few, less than 3 to 5% of the individuals. Most of them are going to have dominant hemisphere to be the left only. If you're going to have involvement of the dominant angular gyrus, you're going to result in a constellation of a syndrome called as Gerstmann syndrome. So what do you mean by Gerstmann syndrome? It's a combination of 4 things, because angular gyrus is very important for calculation, writing, and of course, it's very, very important for the visuospatial recognition also. That's the reason patients are going to present with acalculia, because calculation is a very important function of parietal lobe, and patients can result in agraphia, difficulty in writing, and patients can result in something called left-right confusion. Left-right confusion. Last but not the least, they will have something called finger agnosia. So what do you mean by the term agnosia? Agnosia means failure of identification. If you know how to identify a thing already, and if you're not able to do it right now because of some lesion, that's called as agnosia, failure of identification. Apraxia, on the other hand, is going to be more of failure of execution. For example, you know how to do some task already, but if you're not able to execute right now because of the loss of programs in your brain, so that's what you call as apraxia. Remember, apraxia is not due to motor weakness. Motor weakness may or may not be there, but if not able to do something that you already know, that's what you call apraxia. Agnosia is identification, apraxia is more of an execution problem. We all know that. But on the other hand, if you're going to result in non-dominant, that is right angular gyrus involvement, you're going to result in another peculiar problem that's called as anosognosia. Anosognosia. So what do you mean by anosognosia? Agnosia, it's going to be failure of identification. What do you mean by anosognosia? Anosognosia means somebody is not able to identify their own deficits. For example, I have hemiparesis, but I'm not able to identify that I am not able to move the limb. So inability to identify one's own deficit is what we refer to as something called as anosognosia. Apart from that, patients also tend to develop something called contralateral hemineglect, or otherwise called as hemispatial neglect, which means they tend to ignore what's happening on the other side of the world. Like for example, usually, as I said, your hemineglect is going to occur because of the right parietal lobe lesions, especially angular gyrus. So if that happens, patients are going to ignore what's happening on the left side of the world. Like in extreme cases, they can even fail to shave on the left side. They might ignore food on the left side of the plate and so on. So how can you identify these patients with hemineglect, especially subtle forms of hemineglect? I told you obvious forms, but how to identify subtle forms of hemineglect? By using something called as clock drawing test. You ask the patient, draw a clock. This is called CDT, clock drawing test. Draw a clock. If the patient is having a subtle form of hemineglect, what they will do is they will try to push all the letters towards the right, not towards the left. So you won't find any letters on the left. So this is called as clock drawing test. Or you can ask the patient to strike out certain numbers. You can give a sheet full of certain letters. Like for example, there will be A distributed everywhere. In between, you can mix with certain numbers like 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 4, like that, and ask them to strike off the A's. In the sheet, they will only be striking off the A's on the right side of the paper. So this is another test to test for the hemineglect, subtle forms of hemineglect. So whenever the patient is having involvement of the so-called right parietal lobe involvement, you're going to result in other issues also, like constructional apraxia and dressing apraxia. And even for testing constructional apraxia, you can use the same clock drawing test, because drawing a clock requires a good visuospatial function, and that's what is done by the parietal lobe. If that is affected, then they will not be able to draw a proper clock. So they'll be drawing something abnormally like this. So same clock drawing test can be used to test 2 things. One is hemineglect. Apart from that, you can use it to test constructional apraxia as well. Constructional apraxia does not have any particular localization in the brain. It's kind of a diffuse function of the right parietal lobe. So it's going to occur in some diffuse metabolic states like probably hepatic encephalopathy or any other metabolic encephalopathy for that matters. So other right-sided issues will be constructional apraxia and dressing apraxia. Don't forget.